Assalamu alaikum. Hello, guys, and welcome to our next lecture in our past sessions. Today's lecture is about the biochemistry of alcohol or the metabolism of alcohol. As this session is going to be pre-recorded, feel free to ask me any questions you have, and this is my phone number down there. All right. So today's lecture is basically about the metabolism of alcohol. Now, where do you get this alcohol from? Alcohol is just a beverage that people drink. Now, in our lecture today, we're going to discuss what happens when this alcohol is being drank and basically what the body does to the alcohol and where does it go. So let's start with the lecture. Now, the first thing is going to be the alcohol absorption. As you take anything through the GI tract, the first thing you need to do is going to be absorb it into the bloodstream. And from then, it will do its effects. Now, the main site of absorption for the alcohol would be the upper small intestine. Okay, so the main site for absorption of alcohol is the upper small intestine, or it could be absorbed less, like about 20-25% in other places such as the stomach. Okay, now, once this alcohol is absorbed, what is going to happen is that it needs to get metabolized. This metabolization of the alcohol occurs in the liver. 90% of the alcohol will be broken down in the liver, and the other 10% will just be excreted in your smell, in your breath, or as the expired air, or in sweat, or in urine. Okay? Now, the next thing you need to know is that alcohol is basically empty calories. What is calories? Calories are energy. So alcohol has the energy. However, it's an empty calorie, so it only has energy. It's deficient in vitamins or minerals. So like you can't stay on an alcohol diet. However, it produces energy of 7 kilocalories per gram of alcohol. So if you said, for example, this was an example provided by the doctor. He gave you that basically they take a pint or 473 milliliters of 80 proof, 40% alcohol, provides most of the basic metabolic rate requirements for a day. For example, like if you look at 454 grams, it's going to have 0.40%, and multiply that by 7, because 7 kilocalories is going to give you the total amount of energy that you're going to get from the alcohol. Okay? Now, the major routes of ethanol or alcohol metabolism, like make sure that you know ethanol and alcohol are used interchangeably. So keep that in the back of your head always. Ethanol, alcohol are referring to the same thing. Now, the major routes of ethanol metabolism, you have two main routes. The big one, or the important one that we're mostly going to discuss in this lecture, is basically what happens in the liver. It's going to be enzymes controlled. Enzymes are going to take alcohol and break it down to acetaldehyde by the alcohol dehydrogenase. And then acetaldehyde is going to be broken down to acetate by acetaldehyde dehydrogenase. Okay? Now, the most important thing you need to know from this conversion is that the first step and the second step are producing NADH by converting NAD plus to NADH. We're going to discuss why is it important in a second, but basically, the NADH that is being produced in these two steps is going to be responsible for most of the toxic side effects that the body faces when you're consuming alcohol. Okay? It's the NADH that's contributing to these effects. Now, this acetate, then once we formed it, it's going to get converted to acetyl-CoA, and this is going to be done by an enzyme known as acetyl-CoA synthetase. All right? The other pathway would be including an MEOS, which is a microsomal ethanol oxidizing system. The MEOS is basically a CYP enzyme or cytochrome P450 enzymes. These are a group of CYP2E1. Okay, these are a group of enzymes that are liver enzymes that will be responsible for breaking down like different substances or drugs. In our case, CYP2E1 is going to be responsible for breaking down alcohol. And how you would remember it, because ethanol, and there's the E. Okay, so CYP2E1 is the CYP450 enzyme responsible for breaking down alcohol, and it's referred to as microsomal ethanol oxidizing system. Okay. Now the first pass of metabolism and the second pass of metabolism. Before I go to that, I want to describe the MEOS in a second. Okay. Now, what the MEOS, because the major metabolism pathway is what we're going to discuss most of the lecture. So I'm going to go over this one real quick so that you know what it's about. The MEOS pathway is only going to be activated when there is a high amount of alcohol in your body. When there's a high concentration of alcohol, we're going to activate the CYP2E1-MeOS. And what it does, it breaks down alcohol or ethanol into acetaldehyde, which would then be converted to the acetate. Okay? So the first thing that we got is that the CYP2E1 is activated when there's a high amount of alcohol. And it breaks down this alcohol. So what does it do? It enhances the ethanol metabolism, and this will contribute to create a metabolic tolerance to the alcohol, because you can take in a larger amount of alcohol, which will be just broken down by the CYP2E1 enzymes. Okay, and the other thing that you should know about the CYP2E1s or the CYP2E1 enzyme is that it releases free radicals such as the superoxide, the hydroxyl free radical, hydrogen peroxide, and all these free radicals will contribute to damage to the body. Okay, so you don't want a high amount of free radicals. Usually what happens is that these free radicals will then be reduced by the cell. However, if there's an accumulation of these free radicals, that would lead to damage. Now that this CYP2E1 is clear, we can go over the next of the lecture. Now, the first pass metabolism and the second pass metabolism of alcohol. From its name, first pass metabolism, as it's first passing. Now, as you consume it through the GI tract, the first pass metabolism, or the first thing that's going to be passed, is the GI, which is the stomach. Okay? So the stomach is contributing for the first pass metabolism of alcohol. And this basically contributes to the fact that if you have food in your stomach, this will affect the alcohol metabolism in the stomach and how it's going to be basically pushed through the stomach. Okay? Now, the second pass metabolism is the main metabolism site, which is going to be taking place in the liver by the three enzymes. Alcohol broken down to acetaldehyde by alcohol dehydrogenase. Acetaldehyde is broken down by acetaldehyde dehydrogenase to acetate or acetic acid, and this is going to be metabolized to produce acetyl-CoA. All right. Again, the same concept, the major pathway, the cytochrome P452E1 pathway, which is only activated at high alcohol concentrations. And then the last pathway, which is not really focused on, but basically it's a catalase, which takes place in the peroxisomes. Catalases are usually enzymes that are used to break down the superoxide free, or like the free radicals. That's where we use the catalase enzyme in peroxisomes. Okay? Okay. Let's get to the main or the most important part of the lecture, the alcohol metabolism and the major pathway. Now, what we'll do in the couple slides, we're basically going to degrade this process and describe how alcohol would lead to acidosis or lactic acidosis, to ketoacidosis, hypoglycemia, and excess lipids. See, these red blocks are basically the summary of all you need to know. Like you must memorize that alcohol causes lactic acidosis, ketoacidosis, hypoglycemia, and fat buildup. In the next couple of slides, we'll explain how that occurs so that it would make memorizing it easier. And again, the most important thing that you should keep in mind is that alcohol metabolism is producing NADH. How is NADH contributing to most of these side effects? The first thing that I will basically just point out right now is that where did we say we need the NADH? Remember in the glucose metabolism pathways, we said whenever we're breaking down like in the glycolysis and the Krebs cycle, what we're releasing is NADH. This NADH at the end of the Krebs cycle would all go to the electron transport chain in the mitochondria. The electron transport chain would then convert this NADH into ATP. Now, when you're consuming alcohol, what happens is that your body has a lot of NADH. Okay, there's too much NADH. And this NADH would go to the electron transport chain, which produce too much ATP. Okay, so keep that in mind. Now, we have a high amount of ATP and a high amount of NADH. Okay, let's get started now. The first thing is going to be ketoacidosis. Ketoacidosis. Okay, what happened again? As we said, the NADH is going to be accumulating and the ATP is going to be accumulating. Why do we need the Krebs cycle? The Krebs cycle is functioning to create ATP and NADH. And therefore, if we have high ATP and high NADH, we no longer need the Krebs cycle, right? So the Krebs cycle is going to be stopped. Now, if it's stopped at the rate limiting step, which is the isocitrate dehydrogenase, we're going to have accumulation of the isocitrate, we're going to have accumulation of the citrate, and we're going to have accumulation of the acetyl-CoA. The most important one you should keep in mind right here is acetyl-CoA. From glycolysis, pyruvate is going to be converted to acetyl-CoA. However, we don't need energy. We don't need the NADH. So the acetyl-CoA doesn't have to go to the Krebs cycle. And the acetyl-CoA is going to stay here. And it's going to build up and build up and build up and build up. Okay? This is one factor that's contributing to the acetyl-CoA. The other factor is, remember, we said ethanol to acetaldehyde to acetate. And this acetate is then going to be converted to acetyl-CoA by the acetyl-CoA synthetase. And so we have even more buildup of acetyl-CoA. And now we have a lot of acetyl-CoA. However, it can't go to this pathway. So we can't just leave the acetyl-CoA here. Instead, it will go to another pathway that will basically lead to formation of keto acids or the ketones. And this will lead to ketoacidosis. So ketoacidosis is formed by the buildup of acetyl-CoA. This buildup is caused because the Krebs cycle is inhibited, because we have a lot of energy, and we have a lot of energy and a lot of ATP. And since we have a lot of energy and a lot of ATP, the Krebs cycle is inhibited, and acetyl-CoA is no longer needed to go to the Krebs cycle. It's going to be built up over here alongside the acetate that's going to be converted to acetyl-CoA, and it's going to form ketones or keto acids. Now, this is the first effect. The second effect is hypoglycemia. Hypoglycemia is a decrease in the blood glucose. How is the hypoglycemia going to be caused? Again, it all goes back to the idea that we have a high amount of NADH. If we have high NADH, okay, if we have high NADH, this is going to basically like contribute to hypoglycemia in two ways. The first way is that where do we get NADH from? Right here, NAD positive is going to be converted to NADH, right? NAD positive is converted to NADH. So we have a high amount of NADH, but at the same time, a decreased amount of NAD positive. Where did we need this NAD positive? We needed the NAD positive in glycolysis, okay? We needed the NAD positive in glycolysis. And since we don't have this NAD positive, this is basically going to affect glycolysis, or like a major source of energy in the body. Okay, keep that in mind for a second. Now, the next thing is that the buildup of NADH is going to lead to increase of malate by converting oxaloacetate to malate. Let's take a look back at the Krebs cycle. If you notice right here, the oxaloacetate to malate reaction is a reversible reaction. It can go both ways. If there is a high amount of NAD positive, it's going to go over this way. So if there's a high NAD positive, malate is going to be converted to oxaloacetate. In this case, however, we have a high amount of NADH. So the NADH will combine with the oxaloacetate in order to form malate. Why is this very important? Because where else did we need the oxaloacetate? It was used in the gluconeogenesis to form the PEP and then the glucose, the gluconeogenesis pathway. Now, we have a decrease in oxaloacetate for two reasons. There is a less electron transport chain, or less TCA cycle, because we basically stop the TCA cycle. So there is less oxaloacetate formed. Everything here is going to decrease. And then we converted the oxaloacetate to malate, so even more decrease in oxaloacetate. And therefore, there's a big decrease in the gluconeogenesis pathway. So that's the first contributor. And the next one, as we said, we need the NAD positive for glycolysis. Now, where are we going to get this NAD positive from? Our body has developed a mechanism is in that the pyruvate is going to be converted to lactate in order to generate this NAD positive, okay? And we're building up lactate, which will lead us to the next point, which is lactic acidosis, okay? Lactic acidosis. And another factor that's contributing to the lactic acidosis, other than that the body has, that the body needs the NAD positive, the other factor would be that we inhibited the TCA cycle, okay? Let's take a look back right here. we inhibited the TCA cycle. Therefore, we have a buildup of citrate and the buildup of acetyl-CoA, which is the most important. If we have a buildup of acetyl-CoA, do you think we'd want to convert even more pyruvate to acetyl-CoA? Do you want to exacerbate the effects of the acetyl-CoA that's building up over here? No, we don't want to build any more acetyl-CoA. Therefore, this pathway right here is going to be stopped. And the pyruvate instead will go to this pathway to create the lactate or the lactic acidosis. Okay? Now, so these three metabolism pathways that you should keep in mind for now. No gluconeogenesis, which leads to hypoglycemia, lactic acidosis, and ketoacidosis. The last one would be accumulation of fats. Now, this is basically going to be due to two reasons. First of all, is that alcohol consumption would lead to for synthesis of fatty acids and glycerol. However, this is not the main mechanism. The main mechanism would be going back to the idea of NADH and NAD positive. Notice that all the effects that we talked about were because of the NADH and NAD positive. For fatty acid metabolism or breaking down of fatty acids, which is known as fatty acid oxidation is just like the breakdown of fatty acids or fat in general. This process requires NAD positive. And if we don't have the NAD positive, then we can't break down the fat. It's similar to glucose. You know how we need the NAD positive to break down glucose, and glucose would become a source of energy? We need the NAD positive to break down the fats, and these would become a source of energy. So if we don't have the NAD positive, we can't break down glucose, we can't break down fats. So the accumulation of glucose, or since we can't break down glucose, we talked about what happened in the previous step. And then for this step, or the fatty acid oxidation, since we can't break down the fat, there's going to be buildup of fat. This is you don't need to know much about this part, just that there's be a slight synthesis, like 3% of synthesis of new fat, and mainly there will be no breakdown of fat. Okay? All right. Now, that's all about them. I'm going to go over them again 1 second real quick so that you guys get the idea. It all depends on the NADH positive or the NADH. Okay? We start when there's a high amount of NADH, we inhibited the Krebs cycle. So we have a buildup of acetyl-CoA and a decrease in the oxaloacetate. The main ones are buildup of acetyl-CoA and the decrease in the oxaloacetate. If we have a buildup of acetyl-CoA will be converted to keto acid because it cannot go through this pathway. So it will go through another pathway that will convert it to keto acid. So that's ketoacidosis. If we have a buildup of acetyl-CoA, we don't want to use the pyruvate, or we don't want to use the pyruvate to make more acetyl-CoA. And so the pyruvate will be used in the other pathway, which is going to be forming of lactic acid. If we have too much NADH, it's going to undergo the reversible reaction to convert oxaloacetate back to malate alongside the decrease on the oxaloacetate because there is no the Krebs cycle. So there is an excessive decrease in oxaloacetate, which causes hypoglycemia. And the last effect was buildup of fat because we can't break down the fat mostly. Okay, keep those in mind. The ones in red, you should remember them. Very good. And this is the mechanism behind them. Okay, now the rest of the lecture from now on, it just gets easier. It's mostly just stuff that you want to read them and it will stick in your head. Ethanol excretion. After the alcohol has been metabolized, this is the major pathway, we said 90%. There was 10% that would be excreted in the urine, excreted in the sweat, or exhaled in your breath, right? Now, the next concept is blood alcohol concentration. What this talks about from its name, it's basically the concentration of the alcohol in your blood, like compared to the total volume of the blood. Now, blood alcohol concentration differs according to the weight of the person, but we're going to discuss that in a second. All you need, I'm not sure if you need to know this number, but it's basically this number is specific for a 160-pound person. So I'm not sure if you need to know it. You should make sure with your doctor. But let's assume, let's take the example that the doctor gave you according to this number. So a 160-pound person would have, each drink of alcohol in a 160-pound person would lead to a blood alcohol concentration of 0.02%. Okay? And the alcohol is going to be metabolized by the liver at a rate of 0.02% per hour. This is just the theory. Okay? Let's put it into action. An individual weighing 160 pounds, so each alcohol would lead to a 0.02% of BAC. He consumes 2 drinks. So we have 0.02% multiplied by 2. which is 0.04%. What will his or her BAC level be at the end of that time? Every hour, it's going to decrease by 0.02. So after 1 hour, it's going to be 0.02%. And this is basically some, like with this beer or cola or like whatever it is, going to have 360. And the liquor, there's be 240, 270. This is just how much is found, or like how many milliliters of alcohol. Okay, and this is another the solution of the previous question. We said it's going to be 0.4 the first hour, 0.2%, and the second hour is going to be 0.2%. You're going to add 0.4, and then you're going to subtract 0.2. It's going to be 0.4, and you just build up from there on. Okay, until you get to the 10%. When you're on a 0.1% of blood alcohol concentration, that's when you will be considered drunk, and where you would get like fined for being drunk under influence or driving under influence or whatever. Okay, so at 0.1%, you would be considered a drunk, and that's when you get the fees of like driving under influence. Okay, now the next thing we're going to talk about is the factors that would inhibit the ALDH activity. So these factors, you just go over them and look at them, what they do. Now, first one is going to be antihistamine drugs. Okay, if you're taking these antihistamine drugs, there's going to be like taking antihistamine drugs before drinking prevents the hangover, because there's going to be more metabolization of the acetaldehyde. Okay, the chronic ETOH abuse, or like chronic ethanol abuse, or like if you're drinking alcohol too much, at first there would be increased tolerance, because like your body is adapting to that drinking and increasing the enzymes to break it down. However, if you're going to continue for years, it would lead to reverse tolerance, where your body is like no longer able to tolerate that. Okay, so chronic abuse. If you're aging, an increase in age would lead to increased alcohol dehydrogenase activity, and therefore if you drink a small amount, you're going to have a high alcohol buildup in the body or in the blood. And if there's an increase in the BAC, or the blood alcohol concentration, you're going to get drunk faster. So an increase in age would decrease the activity. The ethnicity, the most important thing you need to know about ethnicity is that Asians have an inactive ALDH, which means that they have a smaller tolerance to alcohol, the specific like Asians. Why? Because ALDH enzyme, there are multiple like genes that contribute to different forms of ALDH. Asians have an ALDH form that's not really good in breaking down this alcohol. Therefore, you can become intoxicated faster by drinking a small amount of alcohol. You're gonna have a lot of buildup in your body. Okay, and then lean body mass. If you're like a higher weight, if you're a fatter person, then your alcohol metabolism, or like you have a greater alcohol tolerance, because you can break down alcohol faster, or other dietary factors like what you're eating or your diet. Okay, now genes associated with alcoholism, I don't think this slide is really important. All it talks about is that certain genes that are going to be contributing to different forms of the enzymes. You can read it and go through it. The ALDH polymorphism, this is a more important slide. Okay, so ALDH polymorphisms, as we said, the ALDH enzyme, there are multiple forms of ALDH. Could be ALDH 1, 2 times 1, or ALDH 2 times 2. These different enzymes will have different affinity to the acetaldehyde, and basically different rate at breaking down this acetaldehyde. Now, extensive flushing is a sign of alcoholism. Okay, extensive flushing is a sign of alcoholism. If there is extensive flushing at a low dose of alcohol, then we can assume that this person or this person's ALDH is not working, because, or basically that he has very weak tolerance to the alcohol. And this would be seen in the Asian people. You know how we said that Asians have weaker tolerance to alcohol because they're gonna be intoxicated faster? This is because they have this form of the ALDH, ALDH2 star 2. Okay, the ALDH2 star 2 is the ALDH form that has a lower activity. Therefore, a small amount of alcohol drinking would lead to a greater buildup. And the ALDH 2 times 1 is found in other people, which would basically mean that, like, if you drink a larger amount of alcohol, you'd be able to keep up with that more, you'd be more tolerable because you can break it down more. Okay, So, and one more point is that if a person is a heterozygote, he has the ALDH2 star 2 or the ALDH2 star 1, means he has a weaker tolerance, but it's not as bad as someone who has ALDH, like a homozygote for ALDH 2 times 2, because he has the ALDH, this is the 2 times 1, which could basically like make up for the loss in the other enzyme. Okay. This slide basically talks about it's that in a period of time, some people thought that they could just inhale alcohol in order to avoid the metabolism pathway, which takes place in the liver. Because if you're not breaking down alcohol to acetaldehyde, if you don't have the buildup of acetaldehyde, you won't, or like the buildup of acetaldehyde and NADH, you won't have the toxic effects from alcohol, right? So what they thought, if they just inhale this alcohol instead of drinking it, they won't have the NADH, they won't have the acetaldehyde, they won't have this toxic effects. However, it turned out to be like not the case, and it was worse, and now it's forbidden to do that. Okay, it's not really an important slide. Now, the following slides are going to be about the harmful effects of alcohol. Again, just go through them real quick. It's not really important. Like, you could get them when you read them. You know that alcohol. Okay, so let's start with the first one, which is liver cirrhosis and liver cancer. We said alcohol is metabolized in the liver, and therefore, if you're drinking too much alcohol, an accumulation of the acetaldehyde in the alcohol would lead to liver damage. Liver cirrhosis is basically scarring of the liver, or that the liver is basically going to start to get damaged and it's going to be replaced by scar tissue. And that's going to be an irreversible process. Liver cancer due to accumulation of acetaldehyde because you're drinking too much. Like, most of you are already aware of this stuff. Chronic metabolic effects of alcohol. Again, just focus on the previous slides of the metabolism pathways. What the basically like the slide that we talked about, how does alcohol contribute to different effects in the body. But as you can see, it's hypoglycemia and a lot of other stuff. But like, just focus on the previous ones. Reproduction, alcohol. You don't want pregnant women to drink alcohol. Because why is that? Because it's a teratogen, and a teratogen causes birth defects. Okay, so you don't want pregnant women to drink alcohol. And thiamine B1 deficiency. If a person is drinking alcohol, that would lead to thiamine deficiency. Why is that? Because these are some of the reasons. Just read them. Familiarize yourself with them. Decreased uptake of thiamine from GIT, inflammation of the stomach lining due to alcohol consumption, decreased liver thiamine stores due to the hepatic cirrhosis or fibrosis, which is the liver damage because you're drinking alcohol, which lead to thiamine B1 deficiency. And this is referred to as Wernicke-Korsakoff syndrome. It's basically like a disease in the brain. Wernicke's encephalopathies and Korsakoff psychosis. It's just a disease in the brain. And alcoholic myopathy is that the alcohol would lead to myopathy. What is myo? Myo is for muscle. Myopathy, so muscle problems due to alcohol, right? And now this slide is important. I think, yeah, these two slides are important. Now the previous slides, meaning you could just go through them real quick, but the following slides are important, okay? So alcohol can be used as an antidote. What does that mean? Basically, if someone has been poisoned by methanol, the alcohol enzymes that are responsible for breaking down alcohol, which is basically alcohol dehydrogenase and acetaldehyde dehydrogenase, can also break down methanol. Methanol, if it's broken down by the alcohol dehydrogenase, it can form formaldehyde, and then it will form formic acid. Formic acid and formaldehyde are basically poisonous to the body, and they're toxins. So you don't want to form these guys. So if someone has taken methanol, what they would do is that they would give him alcohol. So these enzymes, instead of breaking down methanol to form these toxins, they would break down alcohol. And if they break down alcohol, there won't be formaldehyde, there won't be formic acid, it won't be as bad, there won't be any type of toxins in there, okay? So ethanol is used as an antidote because these enzymes can break down methanol, which is, you know, there's an ol. Anything that ends with an ol is mostly like an alcohol, okay? Now, the last thing is the treatment for alcohol. What they do is give them an antabuse or something known as disulfiram. What disulfiram does is that inhibits acetaldehyde dehydrogenase. And if there is a buildup of acetaldehyde, you're going to get the feeling of that you're being drunk when you drink a small amount of alcohol, because this small amount of alcohol is converted to acetaldehyde. If a person who has a good tolerance, what does that mean? a good tolerance means that his acetaldehyde dehydrogenase is working, so it can break down this acetaldehyde. This time, he inhibited his acetaldehyde dehydrogenase. So acetaldehyde has been built up, and therefore, from a small amount, he's going to get the feeling of that he has drunk a lot, and he's going to get intoxicated with the alcohol. And therefore, he wouldn't like that feeling because it could be harmful to him. And that's why he would slowly but surely quit drinking alcohol. So that's basically what disulfiram does. Disulfiram, it's basically like a reverse mechanism, you know? It causes the feeling of being drunk so that you would stop being drunk. Okay? So an antabuse or a disulfiram. Clear? And that's all for the slides. Again, I'm going to go over like the other parts. So after the metabolism, so that like you guys can see what parts are kind of not important and you just can skip through and what are the important ones. So the ethanol excretion, you keep in mind that these ideas that basically ethanol is going to be excreted in the urine and sweat, that's 10%, and the 90% was the alcohol that was metabolized, and the small amount also is going to be excreted in your breath. That's why they do like a breath test for alcohol. The blood alcohol concentration is the amount of alcohol in the blood. The more alcohol in your blood that you have and the more acetaldehyde means the more drunk you're going to feel. And it's affected by multiple factors, such as the age or the ethnicity. Asians have weak tolerance. If you're an old man, you have a weak tolerance. Or if you have a small body weight, you have a weak tolerance, okay? So like in your head, try to imagine an old man that's Asian and he's thin, a thin old Asian man. This guy can't drink alcohol because he has very weak tolerance, okay? And then just take the opposite of that, which would be like a greater tolerance to alcohol. Again, make sure with your doctor if this number is important to know, okay? And now this slide, this is what happened in your DUIs at 0.1%. These factors that inhibit ADH activity, the antihistamine drugs, the chronic ETOH abuse, the aging, ethnicity, lean body mass, dietary factors, the genes associated with the alcoholism. It's not as important slide. What's more important is knowing the ALDH polymorphisms. Basically, ALDH polymorphisms looking at ALDH 2 times 1 and 2 times 2. The main sign that you are a drunk person is basically the excessive flushings and the low doses of alcohol. The ALDH 2 times 2 has a lower activity or lower breaking down of acetaldehyde, and therefore you're going to have a higher or like a weaker tolerance or higher toxication in your body. Therefore, it's going to be expected in Asians. Okay, and the harmful effects: drinking alcohol causes buildup of acetaldehyde, which damages your liver. You can't give it to pregnant women because it causes problem in the baby. It could lead to something known as Wernicke-Korsakoff syndrome because of thiamine B1 deficiency. And this thiamine B1 deficiency and the Wernicke-Korsakoff syndrome is basically like some type of CNS or like central nervous system or brain disorder. Could cause muscle problems. And this part is important, that ethanol, the enzymes that break down alcohol, are also responsible for breaking down methanol. Methanol, once it's broken down, it becomes a toxin or formic acid. Therefore, you want to avoid this toxin by giving the person alcohol so that these enzymes are busy breaking down the alcohol. And disulfiram is a drug or like a medicine that you can give it to the person so that he could get more drunk. And if the person is more drunk, then he wouldn't like the feeling, so he would stop drinking. So disulfiram, what it does, it inhibits acetaldehyde dehydrogenase to cause a buildup of acetaldehyde. And that's it, okay? So let's get to the questions and the practice questions. All right, one thing that I want to discuss, sorry, I just remembered about it, is about the CYP enzymes that we talked about here, okay? Basically, this part, drug metabolism. The CYP enzymes are enzymes, CYP4, the cytochrome P450 enzymes are enzymes that are found in the liver. Later on, like in the second year, you will learn that these enzymes are responsible for breaking down drugs. If you can't break down the drugs because these enzymes are busy with alcohol, then this would lead to like intoxication due to the drugs or drugs are, I'm just talking about like medications in general. If someone takes, like for example, if someone has this specific dose that he needs to take and he took this dose, he is expecting his body to break down this dose, right? By the CYP450 enzymes. However, his CYP450 enzymes are busy breaking down alcohol. Therefore, this dose is not broken down. And the body like doesn't need a high dose of this. Instead, it's going to build up and build up, and it's going to become high dose, which the body wouldn't want it. so it's going to become a toxin to the body. Okay, so this is basically a small point about the CYP 450 enzymes. And then I'm going to go over some practice questions. I'm going to start from here so that the answers wouldn't show. Okay, practice questions. So this is the first practice question that was from the lecture by Dr. Ahmed. So severe anion gap, I'm going to go over the questions and so to try to explain to you guys what happened, what you need to look at. A severe anion gap metabolic acidosis. Okay, so we're talking about acidosis and retinal damage from formic acid. Okay, so see, he said formic acid. This is your clue, formic acid. Formic acid, which is also referred to as formate. Formate, anything that is with like 8 is a formic acid. So methanol, formic acid, from this slide, formaldehyde, these are all going to be leading to toxin. And the patient has a intoxication. So what is the mechanism? Methanol, right? Methanol, formaldehyde, formic acid or the formate buildup due to the methanol will lead to intoxication. The next question, acetate, which is derived from the oxidation of ethanol, acetate, which is derived from basically alcohol, broken down to alcohol or acetaldehyde dehydrogenase, or acetaldehyde, I mean, so alcohol to acetaldehyde to acetate. Okay, what happens? So what's the fate of the acetate? What happens to the acetate? The acetate will be converted to acetyl-CoA. So taken up and going to be converted to acetyl-CoA, right? Due to its toxicity, it leads to necrosis of the liver. Nope, not the toxicity of this guy. We said that the necrosis of the liver is caused by the acetaldehyde. It directly enters the TCA cycle and is oxidized. No, it doesn't happen. It's the acetyl-CoA that does that. It is converted to NADH. No, it is excreted in the bile. Also no. Okay. And this is basically acetate is converted to acetyl-CoA. Which of the following events would be most likely to be observed following acute, or acute is basically like a small consumption or a short-term consumption of alcohol. So someone has been consuming alcohol for a short amount. What happened? Activation of the fatty acid oxidation pathway increases the rate of gluconeogenesis, increases the rate of NAD+ and NADH, or inhibiting of the ketogenesis or lactic acidosis. This is basically describing, you remember the previous slide that we had like this red word? You want to look at this red word and compare to the answer choices. So the first one we said was ketoacidosis, the formation of the keto acids, okay, from the lactate. Lactate is, acetyl-CoA is going to be converted to the keto acids or the ketones. So there is more formation of ketones. So inhibition of ketogenesis, this is not the answer. The next one was lactic acidosis. The pyruvate cannot be converted to acetyl-CoA because we have too much acetyl-CoA already. Therefore, pyruvate is going to be converted to lactate, which is lactic acidosis. And this is the choice right here. So we have lactic acidosis. The next one is hypoglycemia because we have a decreased gluconeogenesis, a decreased rate of gluconeogenesis because there is a decrease in the oxaloacetate. And if there's a decrease in the oxaloacetate, we can't take it to the gluconeogenesis. The decrease in the oxaloacetate was caused by two reasons: decrease in the Krebs cycle and a conversion of oxaloacetate to the malate. These two factors contribute to that. So it's not B. Activation of fatty acid oxidation or breakdown of fat. We said there's no breakdown of fat that's going to take place in this process. So fatty acid instead are going to get stored, and even there's going to be a slight synthesis of fatty acid, and leaves you to the last choice, which is NAD+ and NADH. When it comes to the ratio of NAD+ and NADH, I'm going to just write it down here real quick because some people get confused with it. What they mean, like whenever you see this ratio of NAD+, just put a fraction. NAD+, NAD+, this is NAD+, over NADH, okay? Because he said the ratio of NAD+ to NADH. If he said an increased ratio, means whenever like you see these questions, always look at this number or the first one. An increased ratio of NAD+ means there is an increase in NAD+. But we said that NAD+ is going to be converted to NADH in the metabolism of alcohol. Therefore, this is also not the answer, which leaves us with E. Okay. Now, hypoglycemia, ketoacidosis, lactic acidosis, fatty acids, and all these symptoms are due to the buildup of NADH from alcohol metabolism. I think this is the last question. Alcoholism is sometimes treated with the drug disulfiram. This drug that deters the consumption of alcohol by which of the following mechanisms? It was discussed in the last slide. What disulfiram does is going to be, it will lead to the buildup of acetaldehyde so that the person himself will feel drunk and would stop consuming the alcohol. So which choice is that? Causing ethanol to be excreted, inhibiting ethanol absorption, blocking the conversion of acetaldehyde to acetate. Exactly. So it blocks the acetaldehyde dehydrogenase enzyme, so blocks the conversion of acetaldehyde to acetate, therefore an accumulation of the toxic acetaldehyde. Okay, so answer choice is B. That's it for you guys. I hope the explanation was clear. If you have any questions, feel free to let me know and ask me on my number, the first slide. Thank you so much and good luck on your final exams.